PC to deliver the much anticipated oration at Rehabcon 2025, a moment that honors knowledge, dedication, and the journey of excellence.
Respected dignitaries, we are now moving to the most prestigious Kerala Chapter of IAPMR Oration, which will be done by our past President, Dr. P.C. MURALIDHARAN. He needs no introduction. He is the President of National President of IAPMR and immediate past President of Kerala Chapter. Over to Murali sir. Sir, please.
Back on the front, first starting first page. Good morning to all. Distinguished President of IAPMR Kerala Chapter, Dr. Selvan, Secretary Dr. Zonu, respected teachers, seniors, colleagues, my dear friends. At the outset, let me thank the organizers for bestowing upon me the privilege of rendering the prestigious IAPMR Oration today. I am overwhelmed by the responsibility invested in this occasion and hope that my message would inspire young practitioners to contribute to building up this specialty, making it one of the most sought out after in medical education. This journey has been a learning experience. Each pivotal point in my career brought me into contact with inspiring pioneers whose hard work and commitment in the face of challenges was instrumental in shaping my path. I take this opportunity to thank my teachers, Dr. Hariharan sir, Dr. Ramaswamy Pilla sir, late Ahmed Pilla sir, Chandini ma'am, Dr. Srikala ma'am, Dr. Suresh Kumar, Dr. Gafur sir, and Dr. Suresh Kumar sir for being the driving force behind me in the PG days and early part of my career. I owe a special debt of gratitude to Dr. George Joseph sir, whose benevolence and knowledge of the specialty was a constant source of inspiration and encouragement to me. At this juncture, I cannot exaggerate the impact that distinguished pioneers like Nandakumar sir, Jairam sir, Rajendran sir, Surendran sir, Shashi Kumar sir, Matthew sir, and Santosh Babu sir have done on me. At the beginning of my journey, I had joined PMR in 1992, and I'm currently completing 33 years in this specialty. During these times, our specialty has evolved from a relatively passive domain into an active and vibrant one. Now, why PMR? A couple of months back, I happened to ask this question to my residents. Pat came the response. It's a calm and quiet specialty. My thoughts went back to the responses given by some of the physiatrists in Kerala Journal of PMR. I pondered over the reply and their opinions. Yes, what they said was true to a certain extent, but times have changed. PMR has made significant strides in acute care settings, especially in ICU, HDU, and post-operative settings. The gist of it is that the essence of physiatry is yet to be understood by young medical graduates, even now. NMC had decided to include PMR as a mandatory subject in MBBS curriculum, showing a positive inclination. But they withdrew this with citing no reason. Now, IAPMR has filed a PIL in this regard and is waiting for the response of the court. Yet some of our institutions are still going ahead with postings and lectures in PMR, which is most welcome. Kerala chapter may take this issue and come out with some steps to create awareness among MBBS graduates about our specialty. This is my personal request to IAPMR leaders, Dr. Selvan and Sonu and others. Now, the significant role of PMR as a third pillar in the healthcare delivery system the other two being curative and rehabilitative, and curative and preventive in restoring function, improving quality of life, and promoting independence of patient has to be highlighted. PMR happened to be my destiny because I had just two options for PG. One was general medicine and the other was PMR itself, which was only a fledgling specialty at that point of time. My knowledge about PMR was limited at that time and came through the experience of our teachers, my seniors, Dr. Padma Mohan, Dr. Simon Isho, etc. My sincere gratitude to all of them. I also take this opportunity to mention and thank my batchmates, Dr. Unnikrishnan, Venu Harilal, Abdul Rashid, Dr. Girija, Dr. Prabhash, Dr. Sahadevan, Dr. Srividya, Dr. Prasannan, Dr. Parameshwaran, Saraswati Amma, and Dr. Sakaria, etc., for the support and help rendered during those days. The guidance and inspiration received from Dr. George Joseph Sir helped me to have a consolidated view about my specialty and made me decline the offer to get admission in ortho and medicine during the course of my career. And my sincere thanks once again to Sir for his guidance. These are the snaps of some of our batchmates who were in Trivandrum for the last conference. Now, do you know why our specialty is called so? Even the nomenclature of the specialty has been a vortex of debate. It confuses many and invites discussions even now. We have seen many such attempts in our WhatsApp groups. In spite of several unconcerted attempts, we still stand at PMR. PMR is the official title in countries like India, USA, Canada, and the Middle East. It's rehabilitation medicine in UK, Australia, and Japan. And it is physical and rehabilitation medicine in the European Union. So a major international organization you might have heard is ISPRM, is again termed International Society of Physical and Rehabilitation Medicine. Now there are a lot of controversies existing in our specialty and in the media, and I think I want to stress one is many specialties have changed their name. Our specialty can and should think along those lines if its unique identity can be defined better. It's a thing which we all have to think, work on. Coming to history of our PMR, though aspects of PMR like exercise therapy dates back to the era of Sushruta and Hippocrates, rehabilitation got prominent only during the period of world wars. This initiated the development of a specialty, but the extent to which it grew was limited. The term physical medicine was used for the first time in 1921 in London Hospital in England. This signifies the use of physical agents or physical energy for treating various diseases, disorders, or injuries. Now coming to 1921, it was Dr. Frank Cruson who organized an academic PMR department, not PMR, it's an academic physical medicine department at Temple University in Philadelphia. In 1936, University of Minnesota established the first training program for residents in Mayo Clinic. Initially, the doctors in physical medicine were known as physiotherapy physicians, and an American Society of Physiotherapy Physicians was formed. Later, Dr. Cruson coined the term physiatry, combining two Greek words for physical and healing. And physiotherapy physicians were hitherto called physiatrists. The American Association got renamed as American Association of Physical Medicine, and the rehabilitation term was added after World War II, and it became PM&R. I would like to mention that Dr. Franklin D. Roosevelt, the American president, who himself was a polio sufferer and who underwent recuperative therapy, was an ardent advocate of rehabilitation. Later, Dr. Howard Rusk promulgated the concept of multidisciplinary care involving different service components, PT, OT, P&O, speech therapy, clinical psychology, social work, and vocational therapy. In 1946, the first rehabilitation medicine department in the world in a civilian hospital was established in Bellevue Hospital in New York under Dr. Rusk. And Dr. Rusk is recognized as the father of modern rehabilitation medicine. This was followed by starting of many PMR teaching centers in the US. American Board of Physical Medicine as I told, it was established in 1946 and rehab was added in 1949. Dr. Rusk established a comprehensive rehabilitation institute of New York University Medical Center, which got renamed as Howard Rusk Institute of Rehab Medicine. In the US, many hospitals offered qualitative rehabilitation services. In the European and Asian scenario, European scenario was a bit different. Here, physical medicine got associated with rheumatology and soon got organized to develop musculoskeletal, neurologic, rheumatic, and amputee rehabilitation. High-quality rehabilitation centers have developed in UK, Germany, Italy, France, Austria, Czechoslovakia, Netherlands, Lithuania, etc. The Scandinavian countries like Sweden also have good academic centers like Karolinska Medical Institutes providing rehab programs. We have Dr. Matthew Sir here who can share his experiences in abroad. Japan made a good attempt in medical rehab in 1920s, focusing on polio. Later, post-World War strategists took a different approach, focusing on war victims. Now, community-based rehab units came into reckoning in the later periods of the last century. Middle East also offers good career opportunities for PMR graduates. Kuwait is one country which recognized PMR very early. We have Dr. Shashi Kumar, Dr. Unnikrishnan, Dr. Biju Gopinath, etc. who can share their experiences in the Middle East. Saudi Arabia is one country explored by Indian physiatrists. Qatar, which has Qatar Rehab Institute at present, specifically for rehab. I had my international exposure in Qatar. Coming to the Indian scenario, 2.2% of population is disabled. However, PMR can only claim a slow start dating back to the second half of the 20th century. First PMR center was established in 1955 in Mumbai. In 1960, a rehab project was initiated by AIIMS Delhi, and later this was transformed into the Department of PMR, thanks to Professor Dr. S.K. Varma sir. This was followed by establishment of many rehab centers throughout India. Dr. Mary Verghese, who is a Malayali, settled in Vellore, and Dr. P.B.M. Menon sir, who were two eminent physiatrists who underwent training under New York University under Dr. Rusk, and they returned to India to promulgate PMR. This opened up PMR and led to the status we are now. PMR in the Indian scenario did not have any worthy contribution till 1973, when the 2-year diploma course was started in Medical College Trivandrum. GIRM Chennai also started a course in DPMR at that time. MD was initially started in SMS College Jaipur and then in Delhi. MD PMR in Trivandrum was started in Trivandrum Medical College in 1989, and we have Dr. Nasimuddin sir, who was the first MD candidate in Trivandrum. And subsequently, in 2003, in Calicut Medical College, MD PMR started, and Dr. Shibi, who is now heading the department in Thrissur, was the first candidate there. Subsequently, several states started diploma, degree, and DNB courses. And later, all these diploma courses are converted into MD, which is a program for 3 years. Indian Association of Physical Medicine was established in 1972 and formally registered on 6th July the same year. The present association has adopted this day as Indian PMR Day and has requested all the physiatrists to observe it on 6th July every year. Presently in India, 17 states have PMR in their hospitals. 17 out of 21 AIIMS and 4 national institutes are with PMR departments. Now, IAPMR has about 870 IAPMR registered members and 550 PG trainees. About 300 members are yet to be registered. Kerala chapter has about 340 members till date. Our goal is to achieve 100% registration among all the physiatrists. I request all the physiatrists to get enrolled in state chapter and the national body. This is the status of MD seats in Kerala now. Back in the 90s, the PG seats were very limited, with only 2 MD seats available in Trivandrum and 9 DPMR seats in Trivandrum and Calicut put together. National scenario was no different, with only limited states and very few national institutions and state medical colleges offering them. We have more seats now. And we expect PG seats to be started in medical colleges in Thrissur and Alappuzha where we have full-fledged PMR department. Hope other institutions like Astor, Malabar Medical College, Calicut, SUT, and other medical colleges follow the suit soon. And I especially thank and congratulate KMCT management in Kozhikode for having started MD-PMR, and right now they have 3 seats. And Dr. Vasudevan sir and Dr. Hafiza are the 2 leading team members there. Now coming to the job prospects. My first job outside medical college was at the Kerala Handicapped Welfare Corporation, and I thank late Professor N. Ahmedullah sir for appointing me there. Also, I respectfully thank Dr. Abdul Ghafoor sir for recommending me for a clinic in rural Trivandrum in the last part of my PG days or immediately after that. These were my initial PMR assignments, and from there my march towards the present status as teacher began. The prospects of getting a PMR job was limited at that time, and there were only 2 options: medical colleges and health services, and for which we had to wait for the PSC recruitments. We also had AWH, Association for Welfare of Handicapped, an independent organization which was running allied health courses at that time, and they were in search of a physiatrist, and I was given the task for about a year. Now there are several such institutes and there are a lot of different organizations which run a lot of courses, a lot of hospitals, and this has increased the job prospects of young physiatrists. And I have to tell one thing is that the young physiatrists need not think about their job too much. They have to go forward and get or initiate their career attaching to one of those. Now coming to Wayanad. In 1996, I got appointed in the health services and Taluk Hospital, Vaitiri. My stint in Wayanad was indeed a challenge. There was no physiatrist except for a period when Dr. Jairam sir was in Mananthavadi. The specialty at that time was relatively unknown. And I was also in charge of tribal mobile unit, MO tuberculosis control, medical boards, then also in sports council as a member as well as MO consultant. My efforts began to taste success, and I could bring about changes in the approach of the doctors towards the area after I took over the responsibility. I take this opportunity to thank Dr. Hariharan sir, late Menon sir, Uttaman sir, Babu Varghese sir, and Nandakumar sir, and many of my present colleagues for coming to Wayanad and making a combined meeting of practitioners from Wayanad and physiatrists a huge success. So I just want to stress this because this must have increased awareness about our specialty and led to increased support from all quarters. There were referrals to PMR even from private sector. We also had other responsibilities to train doctors, nurses, and other healthcare personnel in health sector. These help to promote our specialty among the healthcare workers and to some extent among the public. During this period, there were only very few PMR hospitals in the state, especially in the private sector, and only very few departments existed here and there. At this point, I must not forget the launching pad given by Dr. Shashikumar sir in Kochi. He had started 2 centers, one for spine and pain and other for neuro-rehabilitation. Both became successful, and Dr. Shashi focused on prolotherapy and neuro-rehabilitation and established authority in that area. Dr. Biju Ravindran also started his own clinic in Kochi. And at that same time, I was able to start a center in Batteri called Amrita Center. And it was functional for a few years till I moved to Kozhikode. The Sports Council of Wayanad gave me full support at that time, and ours was the only center attending sports needs in Wayanad at that time. So I wish to congratulate and thank Shashikumar sir, and then Biju Ravindran, etc. for their efforts and entrepreneurship to start independent rehabilitation units. Kerala surged ahead in the terms of number of institutions they have started in PMR. And there were institutions in Cherthala where Dr. Unikrishnan, Dr. Parameshwaran, etc. took leadership, and Dr. Febina was there in Perindalmanna later, and to name a few established PMR units, and they flourished well. Now, Kerala has PMR departments in most of the medical colleges and many major private hospitals, and in private as well as in government sector. The private institutions that have started PMR with physiatrists as head include Aster, KIMS, Rajagiri, ICRA Calicut, Baby Memorial Hospital, Caritas, etc. This goes in tune with the corporates like Apollo Hospital, Reliance, Jupiter, MRC, etc. across the country. And this augurs well for the specialty. New centers have been started in Kochi, Malappuram, Kannur, etc. And I congratulate Dr. Rajesh, Dr. Farsina, etc. for their valiant efforts. In 2001, the Medical College Calicut had a shortage of PMR faculties, and hence I was deputed to work there. This opened a new chapter in my career. Then once again, the influence and guidance of George Sir, who was the head of department at that time, made me stick to PMR. My service in the teaching domain brought me close to several stalwarts in PMR like Dr. P. Sridevi Menon, Dr. Vasudevan, Dr. Srijit, Dr. Suraj, Dr. Mohan Raj, Dr. Santosh, Dr. Selvan, Dr. Reba, Dr. Chitra, Dr. Binu, Dr. Pramod, Dr. Hemalada, etc., to name a few. Now, by this time, I could realize the difference in clinical approach that occurs in the periphery and in the medical colleges. The physiatrists in the periphery are the torchbearers of our specialty due to the direct access to the population. My request to the physiatrists in the periphery is that they should make attempts to promote PMR at tertiary levels. This can be done by improving referrals at the subspecialty level. And at the same time, the subspecialty clinics have to be set up in the tertiary centers. Now, 2010 to 12 gave me a taste of PMR outside the walls of government sector, and this was the most productive period in my career, when I could establish contacts with the public without any barrier. The private hospitals also gave me sufficient exposure. My Qatar experience, the Middle East is a blend of cultures, a mix of European, American, Asian, and Arab influences. It was an experience to learn and imbibe the distinctiveness of medical cultures. Rehabilitation there was carried out through acute care settings, which was functional in acute wards, ICU, HDU, postoperative wards, and ICUs. Then rehabilitation wards and long-term care centers. That is, it was carried out in acute care settings, rehabilitation wards, and long-term care centers. Each facility has separate multidisciplinary team and separate care pathways. This ensures structured rehabilitation care to all needy patients. This model of care also delineates rehabilitation and from other specialties and is also worthy of emulation. We have our friends Dr. Krishna Prasad, Dr. Srija, Dr. Naufal, and Dr. Sujit working there now. Now, many centers in UAE and Oman need physiatrists, even though they prefer Western qualifications for consultant posts. Back to Kerala and back to medical education, I am enjoying the clinical work and teaching. The scope of cadre promotions in medical college is limited, but the saving grace was a career advancement program which was introduced. I am also a beneficiary to this. But the whole system and government seats need change so that in academic circles, academic experience should be given priority. And this phase made me reflect on the positives and negatives of our domain. Now, the drawbacks which I could come across is one important point was a lack of uniform protocol in India in treating different countries. This was an experience I laid from Qatar where they asked, what do you do for these conditions? But that I was able to say only that things differ in different institutions. Second is a lack of multidisciplinary discussion and approach in most centers. Yes, we have the multidisciplinary team, but there was no joint involvement. And now things will be having a different turn with Allied Health Council coming up. That is a matter of discussion and debate on for a late turn. We are putting forward it for a later occasion. Now, lack of exposure for physiatrists and internal medicine during the PG curriculum. This is important. I had my experience in senior house in medicine before coming to PM. I did not face much problem, but now what we are coming across among the young graduates is the lack of medicine exposure. And I request our head of departments to take note of it and give postings in ICU and ED for our PGs in the next future. Now, lack of skilled nursing facilities and long-term rehab care. there is limited use of assistive technology, and we are more equipped in theoretical knowledge and misplaced emphasis. Now, coming to scope of development, so a multidimensional approach has to be developed for accomplishment of functional restoration, improving QOL, promoting ADL independence, etc., by multidisciplinary and interdisciplinary teamwork, comprehensive care, and increased accessibility. Following areas have to be identified and worked upon. One is subspecialties in PMR. I think I have mentioned subspecialties here. IAPMR has to strive hard to incorporate some of these subspecialties into our academic array. Now, one point I want to stress is a need for focus on acute rehabilitation. And acute rehabilitation needs more attention due to increasing number of RTAs, worksite accidents, faster pace of living, and awareness of quality of life. This can be carried out in all acute settings. And the role of PMR here will prevent complications, reduces length of stay, and reduces the cost. We should have more workshops, CMEs in this area to facilitate all physiatrists to become competent in these areas. The curriculum in PMR in India needs modification to include acute care, interventions, etc., and internal medicine basics in academic postings. Now, lifestyle clinics, of late, the morbidity pattern in the community is changing, and the prevalence of lifestyle diseases is on the rise. These are mainly the modifiable risk factors for many diseases like stroke, cardiovascular diseases, etc. A proper and structured lifestyle clinic with emphasis on disease prevention, diet and exercises, along with our PT, OT, and P&O, can significantly improve the quality of life of population. Dr. Roy R. Chandran emphasizes the concept of fitness regularly and promulgates the concept of lifestyle medicine clinics. Now, regarding the research and startups, in the era of modern technology and robotics, we still lag far behind. There is need for systematic revision and update. The research and development has to be promoted. During my tenure as state president, our team had introduced financial assistance to those interested in research, but there were no takers. Now the present team under Dr. Selvan and Dr. Santosh has given more importance to research, and under the guidance of them, more efforts have been put in to realize this project. And we also have to find resourceful partners to establish startups and research projects so that use of technology can be incorporated into our fold. Another aspect I wish to stress is the selection of topics for the PG thesis. Many residents choose the topic randomly. My suggestion is to identify the gaps in research in specific areas and address them through their projects and thesis works. Specialist services. Now, physiatrists should take up specialty services like interventional physiatry, hand clinics, diabetics rehabilitation, stroke rehab, cardiac rehab, onco rehab, amputee clinic, sports rehabilitation, lifestyle medicine clinics, etc. Now, outreach services. Physiatrists in the periphery, as I told, torchbearers of the specialty, and the relevance and the need of PMR services may be popularized through outreach clinics. Medical boards, certification camps, disability camps, and special clinics within the community enhance the visibility of PMR. Now, fellowship courses has to be started and forms a need of the hour. Physiatrists has to be well versed in key areas of practice which will identify them as specialists in particular domain. With this view, let me urge the Kerala chapter to initiate the short-term fellowship courses and can even cut down the proposed fellowship courses to a shorter term. CBR is one important aspect we have to consider. We know that rehabilitation occupies a liminal space between the curative and palliative health services. When the palliative care is catered to by several governmental and non-governmental agencies, rehabilitation which has social impact on the community is often neglected. Rehabilitation is often misinterpreted as palliation. Understanding the distinction is imperative to enhance the quality of life and cementing the role of physiatrists in contributing to it. Borrowing the words of our Professor Nandomar sir, for a trained rehabilitationist, neighborhood is full of rehab stories from which he or she would find it difficult to come out. Community is replete with instances of disability and rehab, and a good physiatrist unarguably gets linked with it. Capitalizing on the resources available, physiatrists can transform themselves into an indispensable component in healthcare system. No, physiatrists as agents of change. This I borrowed from an article by our Professor Hariharan sir in one of our journals. All disciplines continue to change with time. The advent of modern technology and artificial intelligence and research processes contribute to evolution of independent and comprehensive strategies in all sectors. PMR is no exception. It's time that we take up new challenges and take the specialty forward. The implications of change can be made visible in curriculum upgradation, treatment protocols, multidisciplinary approach, acute rehab, newer diagnostic techniques, application of advanced technology in robotics and P&O, etc. Developing subspecialty clinics like cardiopulmonary, hand clinics, onco rehab, and subspecialty fellowships. Now, it's the turn of new generation physiatrists to pave way for a positive change for carving out a glorious future. In the course of my 33 years, I was fortunate to occupy several positions in the organizational ladder. I thank you all for the support and help. As I embark upon new role as national president, I aspire to follow the footsteps of my illustrious predecessors. We are facing newer challenges, and I solicit your cooperation in taking it forward in the best interest of our specialty. I am with you, and I just to go through a couple of photographs which I have during my PG days and career. Thank you very much for your patient hearing. Long live IAPMR. Jai Hind.
Thank you, Murali sir, for enlightening presentation. As being IAPMR Kerala Chapter of Oration, no questions are allowed. Thank you once again, sir.
Thank you, sir. Now, may I invite Dr. Selvan P., President of IAPMR Kerala Chapter, and Dr. Sonu Mohan, Secretary of IAPMR Kerala Chapter, to hand over a memento to Dr. MURALIDHARAN sir as a token of our gratitude.